All right, hello everyone, and welcome to this presentation on the topic of organization and financing of healthcare systems, including oral healthcare systems. My name is Jim Crall. I am now Professor Emeritus at UCLA School of Dentistry, formerly the chair of the UCLA section of pediatric dentistry, and also subsequently the Division of Public Health and Community Dentistry at UCLA. I'll just start off with just a brief bit of introduction and give you an idea of my background, and then we'll plow into the topic for today's presentation. Like many of you, I started out the first 25 years or so of my life following a path that probably isn't too dissimilar to yours, in that I went to dental school at the University of Iowa. Subsequently also completed the pediatric dentistry residency program there, and had every intention of going into practice as a pediatric dentist, but an opportunity came along to join the faculty there in 1979, long ago for many of you, and that really spawned a career that lasted 44 years in the academic world in various settings, as you can see from this slide. So I was a faculty member at the University of Iowa, University of Connecticut School of Dental Medicine, where I was chair and head of the Department of Pediatric Dentistry there and director of a children's hospital dentistry program. What really helped define my career was also an interest I developed in health policy and health services research. So I had the opportunity to go off in the mid-'80s to Harvard for a couple of years and study that on a full-time basis. Subsequently got a doctoral degree in health policy and management, which led me to becoming, or at least helped to lead me to become the child advocate for the American Academy of Pediatric Dentistry for a period of about 19 years. So I was working both at the federal and state level. I've worked in 2 federal agencies while on sabbatical from my different academic appointments. Last 20 years, I was at Columbia University for a number of years, headed up a policy center, a maternal and child oral health policy center funded by HRSA. Then came out to UCLA in 2004 and directed a couple of local programs, one funded by First 5 LA, the other funded by the California Medi-Cal program, the Dental Transformation Initiative, and then also had the opportunity to lead a national effort on working with the American Academy of Pediatric Dentistry and the Head Start program, a dental home initiative targeted toward kids in Head Start. So along the way, that led to a number of different types of experiences. I mentioned being the Academy of Pediatric Dentistry child advocate. I had the opportunity to do some clinical training of dentists trained from all around the Middle East and places in a Kuwait program back in the 80s. I served on some advisory committees, including the Title VII Advisory Committee, which those of you that are into the advocacy aspect of pediatric dentistry know that's the program that really has funded the expansion and growth of residency programs and slots all across the country. I worked with the folks who put together the Surgeon General's workshop and conference back around the year 2000, worked with the National Governors Association, so that got me into Medicaid. I wrote the CMS Guide to Dental Care for Children in Medicaid, and even had the opportunity to testify before a couple of congressional committees in the aftermath of the death of Diamante Driver, when attention was directed at the federal level to improving oral health care for kids, particularly those in Medicaid. And most recently, I've also been working with the International Association of Pediatric Dentistry as an honorary editor and a member of the board of directors. I point that out to you to say that at the time I was in my residency program back at the University of Iowa, I couldn't have foreseen any of these experiences coming along or these opportunities. But it's just by way of saying that don't ever underestimate what you as a pediatric dentist might be able to do, and keep an open mind about opportunities when they come along. And hopefully the preparation you're getting in your residency program will help you have the confidence to take on some of these opportunities. I had the good fortune of having a whole host of different types of mentors over the years. Hopefully you will recognize various mentors along the way, and that'll help you find your path, whatever it may be. So enough about my background. The topic for today's presentation, I'm going to try to address these four fairly broad areas. So we've got a lot of material to cover in a relatively short amount of time. I'm going to talk about how healthcare is organized and financed, particularly in the United States, but also to give some perspective of an international comparison. So looking about how we do things in the United States compares with other countries. I'll look at that for the broad healthcare sphere in general, as well as for oral health care or dental care. We'll look at how different countries finance that care, what the healthcare dollars are spent on, and what types of outcomes are achieved. Then I'll move on to giving you at least a broad, quick overview of public health systems, what their functions are, how they're structured, particularly at the federal level in the United States, with a brief mention of activities here in California. And then I'll wind up covering a paper that I co-authored with Dr. Marko Vujicic, who's an economist and the director of the American Dental Association's Health Policy Institute, where we published this paper in Health Affairs in the year 2020 with really a 25-year look back, seeing where we had made progress in terms of children's oral health and oral health care, and also examining how various policies and programs had contributed to that progress, but also with a mind on challenges that still remained and priorities to continue to improve oral health care for kids. All right, so first subtopic we'll dive into is how much does the U.S. spend on healthcare, and how does that compare with spending by other developed countries? Well, if you pay any attention to healthcare and healthcare policy at all, it won't be a surprise to you to know that the United States healthcare spending continues to grow. It grew even in 2010, the year when we were first visited by the COVID pandemic, and it grew at a fairly substantial rate in 2020 by 9.7%, exceeding over $4 trillion, which comes down to about $12,500 per person in the country. As a share of the country's gross domestic product, so the value of all the goods and services that are produced within the United States in a given year, healthcare spending accounts for nearly 20% of our entire GDP. Which, as you will see, makes us a significant outlier compared to other countries. This is a comparison of U.S. spending compared to other developed countries, many in Europe as well as Asia. And you can see, as the slide says, that the U.S. spends 3 to 4 times more than countries like South Korea, New Zealand, Japan. For healthcare, we spend double as a percentage of GDP what most European countries spend. So that really does make us an outlier. This slide shows it more in a graphic comparison over the years. And you can see that back around 1980 or so, we were at the sort of the top of the spending pack, but at least we were in the pack. But then we sort of broke out, not necessarily in a good way. And our rate of healthcare growth of our expenditures has continued to climb at a much faster rate than it has in other countries. And we'll look into why that is the case. You can see that we do spend roughly twice as much of all the value of our goods and services, our GDP, compared to other developed countries. That issue itself, the growth of our healthcare expenditures has drawn attention for many decades now. And this slide shows that even though the growth of our healthcare spending in percentage terms has slowed in recent decades, it has consistently exceeded the growth of gross domestic product. And the result of that is that the proportion of the gross domestic product that goes to health care has continued to increase rather substantially, more than double since 1980. Where do all of those expenditures go? Well, this slide shows that the highest percentage, a little over 30%, goes to hospitals. Another 25% or so goes to a whole variety of healthcare providers that includes things like chiropractors, optometrists, occupational health, physical therapy, speech therapy, whole nursing care, a whole array of things. Physicians and clinics comprise about 20% of U.S. healthcare expenditures. Drugs, retail prescription drugs, about 10%. And of course, dental care comes in at just under 4%, 3.8%. If you look at how our overall spending compares with other countries, you can see that we have a higher percentage of our healthcare expenditures go to outpatient services, interestingly enough, even though hospitals is the largest category of expenditures. And the other issue or consideration that is often pointed out, in spite of these high healthcare expenditures we have in the United States, we cover a smaller proportion of our population with some type of insurance coverage, either public or private coverage. So most other countries have essentially universal coverage of the entire population. In the US, we're at about 90% now of people who have coverage. So second aspect of the consideration is who pays for healthcare in the United States and in other countries. And this slide shows that, interestingly enough, when you look at government health spending, United States, as a proportion of our gross domestic product, we spend a comparable percentage compared to a whole variety of other developed countries. So we're pretty much on a par with many of those other countries in terms of government spending for healthcare. But in addition to that, then what's unique about the United States healthcare system is that we then spend even more in private expenditures, which the combination of those two categories of spending puts us at a considerably elevated total spending rate compared to other countries. This is just a graph that shows a little different way of looking at that, when you can see the public spending, the private spending, and the out-of-pocket spending. And that's the other feature that, in spite of having both considerable public and private spending for healthcare in this country, Americans still are second only to Switzerland in terms of the amount of out-of-pocket healthcare expenditures. The government programs, we don't have time to go into these in details. That's a whole different session we could cover at another time. But the federal programs include Medicare, the Veterans Administration, TRICARE, which is a Department of Defense program covering those in the military and dependents, the Indian Health Service, or IHS, and Title V programs, which are Title V of the Social Security Act, and those are typically block grants that go to the states. So both Title V programs and Medicaid programs and CHIP, or the Children's Health Insurance programs, as well as the ACA exchanges that the states have set up, marketplaces, those are all examples of federal-state partnerships. So whereas the funding for the Medicare program comes exclusively from the federal government, the funding for Medicaid programs comes partly from the federal government, but also partly from individual state expenditures. And then finally, in addition to those different types of governmental programs, there's a variety of community programs, some of which are administered by either governmental or quasi-governmental agencies. An example in California are the First Five programs. So First Five LA is a program that uses tobacco tax money to channel into local county programs that can be spent on a whole wide range of activities for children from birth up through age 5, actually pregnancy up through age 5, and including health care services. The issue of who pays for healthcare certainly has changed over time and continues to change. Back in around 1970, about a third of all the healthcare in this country was paid for directly out of pocket. So the public didn't have the type of insurance coverage, private or public, that they have today, and paid a higher percentage of cost out of pocket. Over that 50-year period, you can see growth of both private health insurance, but particularly growth of public health insurance, Medicare, Medicaid, Veterans, Department of Defense, those types of programs that I showed you on the previous slide. And certainly the COVID pandemic exacerbated federal expenditures, and you can see a huge spike there in federal government spending in the year 2020, 2021, and over time, since 1990, you can see the share of healthcare financed by the federal government increasing from 17% up to 36% now, and of course, a huge increase in spending from $719 billion in 1990 up to over $4 trillion, 4,124 billion, which is more than $4 trillion now in healthcare spending in 2020. So when we look at the healthcare system and the way healthcare is provided across different countries, what really stands out is that in most other developed countries, in fact, in all other developed countries, the public program, there is a public insurance program in place. And in most countries, it's compulsory that people join, and in some compulsory and automatic. You're automatically enrolled if you're a citizen of those countries in those healthcare programs. But in the US, we have some programs well, in fact, all of the programs are considered voluntary in given that even for Medicare, you have to apply for Medicare. Now, Medicare is not means tested, so it means that it doesn't matter what your income level is, that you could be, certainly you should be eligible if you're citizen of the United States to be, you're eligible for Medicare. But you have to apply for Medicare. You have to apply for Medicaid. You have to sign up for private program, private insurance at work. So we look at insurance in a bit of a different way than others do. And you can see the other thing that's really pretty striking is that we have, at least when this paper was written and published in the Journal of American Medical Association in 2019, 880 different insurance firms providing health insurance coverage. And I'm sure that didn't include even the dental plans as well. That's probably the broad major healthcare coverage. And a huge number of establishments and places people need to go to actually sign up for health insurance. Very different than most other countries. You'll also see in the very bottom row that in other countries, there's a category called duplicative or supplementary or complementary insurance. So it's not unusual in this day and age, for even though people in these other countries may have access to healthcare coverage as a public program, like the National Health Service in England, or the various health insurance funds in Germany, they may still have some type of private coverage to complement the public coverage. And if you look on this slide, you can see how that varies across different countries. So in the UK and all these other countries, 100% of people are covered by the government or compulsory health insurance program. But in the UK, 10% of the population also has some type of private insurance coverage. If you look at France, 96% of the population has some type of health insurance coverage. So that's also something to keep in mind, and that's a way of dealing with the issue about if the public isn't satisfied or has concerns about the kind of care or their access to care that they might receive under the universal public program. In other countries, a percentage of the population, those who can afford to buy private coverage, oftentimes do so. All right, this slide finally, just to wind up on the who pays for healthcare, shows the increase in the cumulative growth of per enrolled person on spending by private insurance, Medicare, and Medicaid. So you can see there, since 2008, there has been a fairly substantial increase in growth of Medicaid expenditures, about a 20% growth. But Medicare has expanded at a faster rate, in part because Medicare is a program for seniors, those 65 and older. So the seniors tend to need more expensive and more healthcare services, as well as it's driven by demographics in terms of those in my generation have been a growing part of the population, but that will decline over time, over the next 10 to 20 years, and be replaced by the succeeding generations. But you can see that the highest growth has actually been in private insurance. So there's sometimes more effective cost controls in the governmental programs, in the Medicaid and Medicare program, in part because they cover such a large percentage of the population, particularly those seniors who need care. Next question. So why is healthcare so expensive in the United States? Why are we such an outlier compared to other countries? Well, there's a lot of information that is constantly being published and studies being done to look at that question. And if you can figure that out, and in fact, figure out how to reduce the growth of healthcare costs in the United States, you will win a number of probably large prizes and recognition. But this is a list of what's generally accepted to be some of the major healthcare cost drivers for U.S. healthcare expenditures. First and foremost is the prices, or the amount that we actually pay to clinicians and hospitals and pharmaceutical companies and insurance companies for services or for coverage or for drugs. Secondly, it's now widely recognized that we have a considerable amount of waste in our healthcare system and the way that we finance and pay for healthcare. And I'll show you some details about that in some subsequent slides. There's the notion that we have a greater emphasis on specialty level care and more fragmented care here in the United States compared to many other countries, where they place more of an emphasis on primary care providers in terms of the structure of their healthcare system. We are inclined to both develop and to utilize expensive technologies in the United States. There also is a viewpoint that says that our shift toward more for-profit healthcare is behind some of the increase in cost in the U.S. healthcare system. Looking more sort of fundamentally, my colleague Neil Halpin, who's a pediatrician and health services researcher at UCLA, has, among others, have pointed out that we have a system that was really designed to provide acute care, not chronic care, and that our reimbursement models are set up around providing more services, particularly toward dealing with acute conditions. And we're not very well designed to take care of chronic care, which is actually the emerging types of healthcare that people need in the country. And then finally, there's a growing recognition that our emphasis is placed on sort of downstream kinds of treatment of conditions, as opposed to more upstream efforts to prevent different types of conditions from occurring in the first place, as well as addressing what are referred to as the social determinants of health, the factors that affect where people live and work, and how that impacts their health. So clearly, again, a very complex topic that we don't have time to really cover in great depth here. But those who have looked at it in a serious way acknowledge that, again, that, we actually, it's not that we provide a whole lot more health services, so it's not the volume of services that necessarily result in higher cost in the United States. In fact, it's more likely the case that it has to do with what we pay for those services or for drugs or for administration of our programs. So, here's a slide just showing that it's not that people in the United States are going to the physician way more often than they are in other countries. In fact, we're below the average in terms of physician consultations in all types of settings. We're below the average in terms of the number of practicing physicians we have relative to the size of the population. But the cost is a significant factor. And you can see when it comes to what physicians, other types of healthcare providers earn in the United States, it's substantially more in most cases for different categories of providers than in other countries, and that's a big factor. You can also see the point about the ratio of specialists, and specialists tend to get paid more, as well as our nurses are increasingly costly part of the healthcare system. Generally less costly than a physician, but still not inexpensive as well. So, and then when you look at the pharmaceutical side of things, drugs, a lot of coverage is now provided through insurance for pharmaceuticals, but the spending for that in public programs as a percentage of all the pharmaceutical expenditures is much lower in the United States than it is in other countries. France, 80%, Germany, 75% of drugs purchased through public programs, where in the United States, we still rely on private insurance, which, as I showed on the previous slide, oftentimes doesn't have the negotiating power or leverage to reduce prices on pharmaceuticals, as is the case with other countries. Interestingly, United States, we tend to use generic drugs as opposed to brand name drugs at a higher rate than other countries. But at the same time, we have a lot of drugs that don't have generic analogs that tend to be available at much lower cost, and therefore many of these drugs that are contributing to higher prices in the United States are still subject to very high cost compared to what they're available for in other countries. So you can see the same drug that cost $86 at the time of this analysis on this slide, Crestor in the United States, would cost 41 in Germany and 9 in Australia. So there's a big battle brewing in the courts, actually, because legislation was passed recently, federal legislation, that gave the Centers for Medicare and Medicaid Services the ability to now negotiate for a limited number of drugs, to negotiate as a purchaser with the pharmaceutical companies. But the pharmaceutical companies are going back and fighting that in the court. And so we'll see if the tide will turn, or how soon the tide may turn, in terms of being able to use greater leverage to negotiate down the cost of some of these very expensive, or can be very expensive drugs, even things like insulin, are very expensive. Turning to the topic of waste, this is again a paper published in the Journal of American Medical Association, where they're looking and estimating that as much as 25% of our total healthcare spending could constitute various types of wasted spending, either from things such as lack of adoption, not really favoring the preventive type services, to things like readmissions, where conditions aren't treated adequately the first time and people end up going back into the hospital, overuse of end-of-life care, so incredible amounts of money and resources that go into care within the last 6 months to 12 months of an individual's life. The issue about our what's called medication pricing failure, or failure to use the leverage that public programs might be able to obtain, and at least they do in other countries. Fraud and abuse, it's constantly see headlines of multi-million-dollar, if not greater, fines and settlements from people who are abusing just out and out fraud and abuse of Medicare and Medicaid systems. And then waste coding and billing. Again, different types of waste that we don't have time to get into, but 25% is a huge percentage of our expenditures that could in fact be put to better use or reduce the overall cost of healthcare. I showed earlier that we don't have more physicians than other types of healthcare providers. We tend to have a lower percentage of primary care providers compared to others, and we tend to have a bit of a higher percentage of specialists compared to others. We do use that more expensive technology, and we develop a lot of that technology, but we also use it at a higher rate than most other countries. We're sort of middle of the pack when it comes to use of services, the number of people that are actually getting care for things like acute myocardial infarction, heart attacks, pneumonia, obstructive pulmonary disease. So we're kind of, middle of the pack when it comes to, who's actually getting the services. But we do a lot more of things that in some countries are more elective in nature, things like knee replacements and hip replacements, cesarean deliveries, etc. Cataracts, we tend to do more of those than the other countries. Other factors that contribute to higher healthcare costs in our country, one of which is just obesity. The U.S. leads the pack, not something we're proud of in terms of the percent of the population that's considered obese. And we also have a higher percentage of people who have multiple chronic conditions, and those get to be expensive to care for. So that brings about the whole question about things like lifestyle and why is it that Americans have these multiple chronic conditions at a much higher rate than many of our other developed country peers. What's remarkable about that is that I mentioned earlier that our healthcare system really isn't all that well designed to deal with chronic conditions, which is the growing component of what we're faced with in our healthcare system. Again, studies have been done that generate estimates that suggest that, clinical care itself actually only contributes about 20 to 25% of healthcare outcomes in terms of life expectancy or quality of life, and that a whole host of other factors, such as various types of human behaviors or habits or dietary practices and social economic conditions are much more important factors in determining life expectancy and quality of life. And that's starting to change, or at least to create discussions around how we can help to make that shift to be more effective. And this slide highlights the fact that, as I said, in the United States, our public spending on social programs really just isn't as high as in other countries. We're sort of at the bottom of the range, and most of that is, in fact, public spending on these social programs. And why is that important? Well, if you look at it, this slide, I think, really highlights that we're an outlier in the balance between what we spend on healthcare in what we spend on social care. And as the evidence continues to mount for the importance of also paying attention to social care as well as healthcare, I think it's likely that we'll see that balance in the U.S. change over time. Clearly, with the situation with respect to the growing federal debt in this country, we're not going to be able to continue to keep just spending more on both of these things. And so it's at some point in time, there's going to need to be a shift, I think, in the balance to help get us better outcomes for what were our total expenditures combined for healthcare and for social services. So let's take a look here now at the just what do we get for all of this funding that we spend on healthcare in the country. We'll start off by showing that despite the fact that we don't provide as broad a coverage, this slide just sort of summarized showing that we spend considerably more than the other countries. So we've seen that before. And also we've seen that, you know, in terms of the obesity and life expectancy, we haven't focused on life expectancy. I've spoken about it in general, but you can see that life expectancy, this is an analysis, again, published in 2019 in JAMA, U.S. average life expectancy at that time, 78.8 years. In Japan, it was 83.9. So, you know, five years longer on average. Health adjusted life expectancy, 5 years higher in Japan. And in places like Switzerland and Australia and France compared to the US. So graphically, it looks like this. Life expectancy at birth in the US at the latest calculation or estimate was about 3 years on average, lower than the average for these other countries, and you know, up to 5 or more years lower than the highest life expectancy in many of these other countries. And we also have a much higher rate of avoidable deaths per 100,000 population compared to the other countries. So you can see we're just an outlier, not only in terms of the expenditures, but also in terms of the outcomes of healthcare, looking at things like life expectancy, quality of life, or avoidable deaths. The COVID pandemic highlighted some of the shortcomings of our healthcare system to be able to deal with a condition like COVID-19. And you can see we had, among all these developed nations, the highest rates of death per capita compared to other countries, with the UK being second, and then many of the other countries having far fewer deaths from COVID than we had in the US. We haven't done particularly well when it comes to maternal and child mortality. Maternal mortality considerably higher than the OECD or developed countries average, and infant mortality still being substantially higher than the developed country average. So in the other slides, we were looking at the trend in terms of US versus other countries over different times. This slide actually sort of helps us do a three-dimensional look at that. And it's looking at a plot of life expectancy on the y-axis and healthcare expenditures on the x-axis. And again, you can see if we go back starting around 1980s, late 1970s or 1980, the US did not parallel or stay with the progress being made in terms of the other developed countries. And in fact, what's even more alarming is that in recent years, life expectancy in the United States has actually declined overall, in spite of the fact that we have the most expensive healthcare system. So that is really leading to a considerable amount of attention as the public becomes aware of the fact that healthcare is not only incredibly expensive in the United States, and by some measures, it's not particularly all that effective. So if you look just at this slide that looks at the expenditures, this is ranking by expenditure, US and the other countries. And you can see, we're at 77 in terms of life expectancy, whereas other countries for half the expenditure per capita have maybe 6 years more of life expectancy. Another way of looking at it is if you look at where we are in terms of life expectancy at 77 years, there are other countries that are spending small fractions of what we spend and still have comparable life expectancy. So that is really calling attention to the fact that change needs to happen. Another slide, just looking over time about how we compare in terms of cost. We are at the top when it comes to per capita cost, but we are not at the far right when it comes to life expectancy. Just different ways of representing this. And you might think, well, how quickly can you actually change life expectancy? What can be done about it? This, interestingly enough, shows many countries, including many developing countries, not necessarily industrial or developed countries, but looking at the improvements of 30 countries and life expectancy since 1960. And you can see in many of the cases, there have been, dramatic increases in life expectancy from 1960. Look at places like Liberia going from 32, which was very low at the time, up to 62. Or look at Libya, 46 to 77 over a period of about 60 years. So, even places like Japan, which are now in South Korea, very highly industrialized and developed countries, they, back in the 1960s, were sort of toward the bottom when it came to life expectancy. But now Japan is at the top, essentially in terms of life expectancy. And South Korea has made tremendous gains over time. So, it is possible. And remember, these countries are spending a whole lot less than we are. So at least surveys that have been done are clearly showing that people in the United States are not satisfied with our healthcare system. Only 19% would say the U.S. healthcare system works well. Over half people say fundamental changes are needed, and a quarter of people say you need to completely rebuild it, the healthcare system. So all I can say for folks of your age, expect changes over time. Keep your mind open and be aware that changes are going to happen. Your dental practice, if you choose to practice, is not going to look like your father or mother's era dental practice or your grandfather or mother era's dental practice. So keep that mind open about and being open to changes that are undoubtedly going to come. Okay, so we'll shift now from the sort of broad healthcare system down to dental care. And review some data, mostly from the ADA's Health Policy Institute, showing here expenditures on dental care, which for a considerable period of time, from about the year 2005 or 6, all the way up through 2015 or 16, were relatively flat. overall. There were some increase there, but not nearly at the rate of other types of healthcare expenditures. And most of the growth in overall healthcare expenditures in the US of late have actually come from government programs. Because the overall healthcare expenditures are increasing faster than the rate of increase of dental expenditures, the percent of healthcare expenditures that go for dental care have actually declined a bit, even though the aggregate total amount of expenditure has continued to increase, and definitely in the last year or so has shown a bit more of an increase in the rate. So, overall expenditures, as I said, have continued to go up. We could definitely use some more recent data from the ADA, but the data that I have seen have shown that post-pandemic expenditures are back up on the rise. Dentist incomes, a combination of economic times, the number of dentists actually being produced since the growth in the number of dental schools and dental school graduates has happened since the 1990s, combined with the fact that overall spending by the public has been pretty flat, resulted in some decline in dentist income. But that's definitely not universal or equal across all the states. This slide, again, compiled by the ADA, shows average dentist general practice income in different states. And you can sort of see the differences that if you look at, say, California versus even places like Texas or Ohio, you can see differences in dentist income. Now, some of that has to do with the fact that the Medicaid programs in many of those states have increased their funding for dental services, not quite to the level that most dentists would like to see, but some, as I'll show you at the very end of the presentation, by a considerable amount. So who's getting dental care and who's covered by dental care? Well, children. The good news for us is that children have the highest level of coverage, and most of that is because of the Medicaid program. And so the combination of private insurance and mandatory coverage for dental services as part of what's called EPSDT benefits of Medicaid mean that kids have the highest levels of coverage. Seniors tend not to have high levels because dental services are not typically covered certainly in traditional Medicaid, but dental services oftentimes are covered. Dental insurance can be provided in what are called Medicare Advantage plans, which add benefits for eyeglasses, optometry services, hearing services, dental services that aren't a part of traditional Medicaid. And then, of course, the working age public tends to get most of its coverage through employer-sponsored insurance. Where are the gaps? The gap in terms of coverage is relatively small when we look at children compared to adults. And that's because at the state level, states are not required to provide dental coverage in Medicaid for adults. And there's varying degrees of coverage across different states in terms of just what's covered and who's eligible for those services. ADA Health Policy Institute has pointed out that dental out-of-pocket payments for dental care is a relatively high percentage of overall out-of-pocket expenditures for healthcare. And that's because dental care generally requires deductibles and co-payments, and all services aren't covered, as well as the fact that we have a much larger percentage of the population that doesn't have any type of coverage. And so any dental care that they get, they end up paying for out of pocket. Who gets dental care in the United States? Again, from the standpoint, the good news from the standpoint of pediatric dentists, children are the higher percentage of children tend to use dental services compared to other age groups. Certainly compared to seniors, but even more so compared to working age adults. And you can see that there has been a decline that is starting to come back in terms of use of dental services by working age adults, but that's actually the group. And again, many of them don't have coverage through the workplace, or if they do have coverage through the workplace, things like cost sharing keep people from using services. So that's likely to receive quite a bit of attention by politicians and the policymakers. You've heard proposals about looking to include dental services as a component of Medicare. Hasn't really happened as of yet. And there's growing attention to what to do about the working age population as well. We know all too well that disparities still exist, even though we have made progress in terms of reducing disparities in use of dental services. So access has improved quite a bit over the years. I'll show you some slides detailing that in just a bit. But still tremendous disparities between the most well-off segment of society, our society, and those at or below the poverty level in terms of use of dental services, both for children as well as for adults and seniors. What do we know about dental outcomes? Well, not nearly as much as we do about other types of healthcare outcomes, but some data that we see, at least in terms of a metric called bad teeth, which would be equivalent of kids who have teeth that need dental care. This index, showing that the U.S. does not as well as some of the Scandinavian countries, but better than some other European countries or Canada or even Japan in terms of oral health of 12-year-olds. And we do know that we have made progress. The most recent U.S. Surgeon General's publication and report issued by the National Institutes of Health showed that there certainly has been a reduction in untreated tooth decay in children, not necessarily as much of an impact on the overall prevalence of tooth decay, but at least the decay that is occurring, a higher percentage of tooth decay in children, and in particularly young children and children who are members of some of our racial and ethnic minorities are getting services at higher rates than they have in the past. So some progress being made, lots of work still to do. So in terms of the overall summary, before I shift to talking about the public health system, in general, the U.S. spends considerably more than other developed countries per capita and on a percent of GDP basis. Despite those higher expenditures, the outcomes that we're seeing in terms of life expectancy and avoidable deaths, quality of life are not as good as in many other developed nations. We use a markedly different approach for organizing and insuring and covering and financing our healthcare than other developed countries, and there's growing public dissatisfaction with the healthcare system. With respect to oral healthcare, we still have some substantial gaps in both coverage and disparities with respect to health status and utilization, and a significant component of overall healthcare out-of-pocket costs are going toward dental care. So that acts as a barrier to people getting dental care. So To wind up here with a bit of a review of the public health system in the United States, and a little glimpse at public health in terms of the state of California. These are the 10, what are known as the 10 essential public health functions. So public health is really meant to take up the mantle for things such as monitoring health status, both to identify problems, and we saw that certainly with the COVID pandemic, where trying to identify where were the hotspots and in terms of COVID, and also to look to assess how effective we are in terms of preventing or treating different conditions. Public health agencies such as the Centers for Disease Control and Prevention play a prominent role there, as well as state health departments. Public health function to diagnose and investigate health problems and health hazards. So a lot of monitoring that goes on, everything from ratings of different restaurants, et cetera, to workforce types of hazards, monitoring by OSHA, Environmental Protection Agency, et cetera. Public health looks to inform and educate and empower people about health issues, to try to educate that public so that they can be healthier, to mobilize community partnerships, to support the development of policies and plans that work for both individuals and communities, to enforce laws and regulations that protect health and safety. Again, looking at things like OSHA or EPA, water quality standards, food standards, drug standards. Public health looks to help connect people to personal health care services. Public health does provide some personal health care services, but it's a relatively minor role compared to the public sector in terms of providing services. But public health really does work to help link people to personal health services that they need, to assure a competent public and personal healthcare workforce. So the federal government, through Title VII programs, clearly has helped to grow the pediatric dental workforce. We have more than doubled the number of training slots for pediatric dentists throughout the country, and increased the number of pediatric dentist providers to help provide a more knowledgeable workforce. And it's not just all about pediatric dentists, after all. Pediatric dentistry educators help to train general dentists and others in oral health care for children as well. Public health plays a role in evaluating the quality of healthcare services, the effectiveness and the cost effectiveness of services, as well as to conduct research on population health and innovative ways to improve health. So that's what public health is supposed to be about. At the United States and in the federal level, this is the organizational chart for the U.S. Department of Health and Human Services, or DHHS as it's often called. It includes agencies such as the Administration for Children and Families, which oversees the functioning of the Head Start program throughout the country. The Centers for Medicare and Medicaid Services, so pretty self-explanatory, overseeing and working with the states and providers for Medicare and Medicaid beneficiaries. The Agency for Healthcare Research and Quality, which conducts health services research with federal funding. HRSA, the Health Resources Services Administration, provides funding for our federally qualified health centers, community health centers, for health professions education, for things like our Title VII program, and also for other programs, maternal and child health programs, HIV/AIDS program, and a variety of other types of programs. CDC, I already mentioned in terms of monitoring and educating the public. the Food and Drug Administration, overseeing the approval of drugs and various types of devices. Indian Health Services, serving that segment, the Native American population. National Institutes of Health, conducting research of various types, including the National Institute for Dental and Oral and Craniofacial Research. And then the Office of the Inspector General, which sort of oversees or does focus studies on the effectiveness of all of those different agencies. I highlighted the picture in the middle of this particular chart is Dr. Natalia Chalmers. Happy and proud to say that Dr. Chalmers is the most recent appointee as Chief Dental Officer at the Center for Medicare and Medicaid Services in Washington, D.C. She is a pediatric dentist and is doing a tremendous job of helping to support and improve oral health, not just for kids, but for all Americans. And it's great to have a pediatric dentist in that spot. So just goes to show you never know when you start out in your residency program where you might end up. At the state level, I just wanted to highlight the vast expansion of oral public health in the state of California, starting around 2015 or 2016. And that stemmed from something called Proposition 56, where the voters of the state of California voted to increase the tax on tobacco and electronic cigarettes to help fund healthcare programs. So the first program of that sort were the first 5 LA programs, first 5 California, and first 5 all the different counties in California programs. But in Prop 56 really helped to expand that. And as part of that, the California Dental Association contributed around $1 million to the campaign, the marketing campaign, to try to convince voters to pass that initiative. And when they did, what it meant was that nearly $30 million a year started to flow to the state oral health program, which is headed up by Dr. Jay Kumar, who came to California from New York and now has a considerable staff and a program that's channeling funding through all the different counties and health jurisdictions throughout the state of California. Has just made a tremendous difference in terms of a dental public health presence and program in California. Finally, in a few minutes I've got remaining here, I just wanted to cover this paper, which I'll provide for those of you to read who want to look at it in more detail. But it's a paper that I co-authored with Marco Vujicic of the ADA Health Policy Institute, looking back about 25 years at how far we've come, but where our gaps still exist and things that we continue to need to do. So I won't spend time going over the various challenges and recommendations we made, but I did want to highlight what I think are some of the milestones that have occurred over a period of 50 plus years now that have helped to improve oral health. Not in a smooth fashion, not without a lot of consternation and finger pointing, but it has brought a lot of entities together, not just dentists, but broadened the attention that oral health has garnered and turned into both programs and policies that have helped to improve oral health over time. Our focus was on children, and so an appendix that goes along with this publication, I tried to highlight over different segments of time, in this case 1996 to 2000, some of the events that occurred and how they tied back to different federal public health agencies or sometimes to the Congress itself. another period of time from 2001 to 2005, 2006 to 2010. So you can see a lot being done over this period of time in different agencies that help to do things like make sure kids had better coverage and make sure the programs that were operating, Medicaid, CHIP, et cetera, had better financing and actually also were performing better. This slide shows the changes over time in terms of one thing you'll notice in line 1A, the number of children in this country who are now covered by Medicaid increased dramatically from back at the turn of the century and particularly the late 90s. So we're over 42 million children in the country now covered by Medicaid. In California, over half the kids are covered by Medicaid. But you can see the improvement, not only in terms of the percentage, but if you consider the fact that we went from fewer than 1 in 5 kids getting any who were covered by Medicaid. 1 in 5 kids covered by Medicaid got dental services back in the mid 1990s to where in 2018 and now the current time, roughly half the kids in the country get some kind of dental services. Half the kids who are covered by Medicaid get some kind of dental service. And the vast majority of those get preventive services. And most of those services are provided by dentists or under the supervision of a dentist. That's what line 12A is. Line 12F shows those services provided by that aren't provided under the supervision of a dentist or are provided by a non-dentist provider. So that would be your primary care providers, maybe pediatricians, family physicians, nurse practitioners, et cetera, as well as a community program. So great improvements over time. Still, the glass is only half full. And I'll wind up with this slide finally that shows differences still, considerable differences still across different states in terms of how well kids have access to dental services. And the good news is that if you look at the far left side of this slide, you'll see that we have some states in this country where a higher percentage of kids on Medicaid use dental services than kids who are covered by private dental insurance. That's not true overall. Overall, about 67% of kids covered by private insurance get dental services within a year, whereas only about half of the Medicaid kids do. But in some states, a higher percentage of kids on Medicaid see a dentist in a year than those who have private coverage. It just goes to show that it can be done. It takes a lot of work and effort, and I sincerely hope that at least by getting some understanding of the overall healthcare system and the big picture and where the gaps still remain, that you will feel compelled to join in our collective efforts to improve oral health care for kids over time and ultimately oral health for kids over time. Changes are happening pretty dramatically. It sometimes seems like we're not making much progress, but I can tell you from somebody who's been around for a few decades, when you go and look back, progress has been made, and it's clearly up to you, the new generations, to continue to help those improvements to continue. So thanks for your attention. Sorry it was a rather long presentation, but at least you have the ability to take it in small bits if you choose. Thank you, and best wishes in your career.